Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Jibanananda Satpathy from Virginia, United States. Dr. Satpathy is Associate Professor and Director of Trauma at the VC University in Virginia, United States. After his orthopedic residency in PGI Chandigarh, India, Dr. Satpathy did higher surgical training in the UK. He then completed his fellowship in Arthroplasty and Trauma at the VCU Health System in Virginia, United States. Dr. Satpathy has been doing trauma and arthroplasty with interest in pelvic acetabular surgery for over 20 years. He's currently the Director of Trauma in VCU Health System, which is a level 1 trauma center serving the state of Virginia. His multiple publications with focus on reconstructive surgery as well as trauma, notably on femoral retroversion, as well as periprosthetic fractures and geriatric fractures. If you've noticed, Dr. Satpathy has delivered a couple of lectures on a channel and it's already reached a huge audience. And today it's my great honor to bring back Dr. Jibanananda Satpathy for this wonderful live program. Over to you, Jim.
Thank you, Hitesh. Thank you for the opportunity. I will be presenting today about complex revision total hip arthroplasty. This is a pretty big topic for me to cover the entire thing. So I will try to focus on some of the tips and tricks and some of the common ways to reconstruct some of the complex stuff involving bone loss on the femoral and acetabular side. So I will start with my workhorse approach that will be extended trochanteric osteotomy. Anybody who is doing a hip revision should be very familiar with this. This is a very useful tool. So I'll start with this. What you need for this, commonly a saw. I use a TPS saw, which is like an ACL blade saw. You can use a standard System 8 as well, just it leaves a bigger bone gap. Flexible osteotomes, pencil tip burr, especially to curb at the bottom end of the osteotomy to make it a nice and curved end rather than a square end. Jiggly saw or giggly saw. This is a very useful tool. I've always used this, especially to debarm the medial side of the stem after you do the osteotomy. Triflange, especially useful on our cylindrical stems. Obviously, regular osteotomes to stack it to remove the osteotome fragment. And then obviously for the repair, you need the wiring tray. This is the basic stuff that you would need apart from the other regular stuff. So when to do it? Typically a well-fixed, fully coated stem, some selected cemented, as well as some uncemented, well-fixed stem that may not be fully coated. A well-fixed cemented stem that requires cement removal. There's extensive cementing and it's well bonded. It's very difficult to take it out without ETO. If there is a proximal femoral deformity that requires an explant and a replant, it'll be very difficult to put a straight stem. So it'll be almost like a corrective osteotomy. Sometimes you have to even complete the ETO to make it like a femoral osteotomy if necessary. But typically, with some proximal varus remodeling, ETO would be sufficient. Now, some of the tips and tricks. This is published. Typically, I use around 12 centimeter, at most about 15 centimeter. There is some utility going over 15 in certain case, but it does make a higher risk of femoral fractures. As you can see, typically I would measure it from the tip of the trochanter, mark it out. I would elevate the vastus lateralis. I would stay anterior to the gluteus maximus, which is attached to the gluteal tuberosity right here. The top part of the cut, I like to do it right over the shoulder of the stem if possible. Many times people do a little bit lower down and it's very difficult to lift up. Now, obviously you have to be mindful not to make it too thin, but typically you get away if you stay right along the shoulder of the stem. Typically, that will be easy to go with the saw across or even the osteotome across to lift the fragment up. At the bottom end, as it's shown, I use a pencil tip burr to curve it down. If you make it a rounded end, there is a less risk of a stress rupture and a propagation of the fracture. Many times, I would also put a wire distal to the osteotomy to prevent this propagation or distal femoral sap fractures. Once you complete the osteotomy on the lateral side, I would also use a saw on the medial side And sometimes people advocate to strip less soft tissue, and they would go through the vastus lateralis without lifting the vastus lateralis much and use a drill bit to make the lateral surface more weaker or the medial surface more weaker, and then lift it up. And this is okay. I haven't seen any difficulty lifting the vastus lateralis and using a saw on the other side as well, or even an osteotomy on the other side. I have not seen a non-union of a ETO. I haven't seen any complications. Again, it's a choice you can make. And then to lift the osteotome fragment, I use stacking the osteotomes like it's done. You have a different level. I usually overlap it a little bit so that ultimately it lifts up. Make sure you finish the anterior cut on the trochanter. The weakest area for this would be the junction of the greater troch to the rest of the shaft. Typically, it will break right there. And the usual reason is this is well fixed up here and the osteotomy is not completed proximally. So something to think about and be careful. Proximally, patience is virtue here. Take your time. If you break it, it's not end of the world, but certainly leaves a sore spot. And then I usually repair with 3 wires. As you can see, this is a post repair. 2 wires, one right close to the tip of the osteotomy, then one in the body. The third one, I use a figure of 8 technique. I use this wire not posteriorly, so it pulls the fragment more posterior. As you have, if you have done it before, you would see that the migration is typically anterior. The abductor pulls it more anterior. So I use this loop posteriorly, and this wire goes right through the abductor muscles. I use a wire passer to pass it through the abductors, and it tends to hold from any superior migration as well as anterior migration. This is an example of when you're going to remove a well-fixed stem that may not be fully cylindrical or fully coated. And the reason here is you can see there is a big medial collar. You cannot go past an osteotome on the medial side. In this situation, this is very well fixed, as you can see. Well, you have access laterally, you probably can debond it laterally, but this is where most of the stuff will stick and it'll be very difficult to get it out. So one of the indication for me would be like a collar stem that is well fixed. So as you can see, it's the post-ETO, the figure of 8 wiring technique, as I showed on the other picture. And then this guy healed really well and had a second stage later. This is another example of a fully coated, well-fixed cylindrical stem, or nearly fully coated. It's the 3/4 coated. This is a monoblock stem. This was done in 1982. I had a tough time with this, and we planned this. This is a grade 3B without discontinuity. As you can see, the cup is actually almost at the SI joint. So I had to do a ETO as well as cut the stem and use the Triflange to remove the rest of the cylindrical stem. And this worked well. This guy healed well and did well till his death. This is another example of what I was talking about, where you have to remove the cement with the deformity proximal femur. This is done in 1978, so you don't even see the radio opacity of the cement. Almost looked like uncemented, but there was a fair amount of cement throughout the canal here. Again, it required ETO, nice and straight stem. This guy's doing well. It's almost 1.5 years now. This is some of the complications of ETO. This is a case, again, I did it. I did the initial ETO as well. So it's a revision of the ETO for a periprosthetic infection, and this is the second stage. After the second stage, the reimplantation, you can see obviously it was in fragments. I had a femoral staff fracture that we wired it, put initially a spacer nail, and then subsequently had a second stage, and you can see the bone actually healed. But something to be careful about, a complication of ETO with the peri-implant fracture or periprosthetic fracture or a femoral staff fracture. Sometimes ETO, if you do ETO and end up with a situation where you can't get it further And sometimes, so particularly when I use summit stem, I usually see that the stem, even though it's only proximally coated, it seems to grow in all the way down to the tip, and almost to the tip, you can't get it out. Many times, a 15 centimeter ETO is not enough. And then sometimes I have to extend it. So the typical way to extend is what we call episiotomy. I would do a little split of the femur. Now be mindful that this split can go all the way down, so you have to wire it below the split where you want to stop the split. You need to make sure you wire it if you extend it. This is another technique. If you can't cut the stem, you can do episiotomy of the ETO further down, so it opens up the space and allows the stem to come out many times. This is a technique you can use. Or you can plan a longer osteotomy from the beginning. This is a paper published from our university where we compared intact femoral specimens with ETO, with and without ETO, and then a repaired ETO, and then after the implant was put. As you can see, you never achieve the strength you have normally in a normal femur, or even with the one with the implanted non-ETO femur is obviously the strongest, but you never reach that even if you repair it. It's always low. It's almost 74% strength, not 100%. So there's always a high risk of fracture of the femoral shaft after the ETO, and be very careful how you rotate, how you force it, how you move it. It's not uncommon to break the femur, especially with the longer ETOs. Lessons learned: minimum length 12 centimeter, typical 15 centimeter. Curve the distal end, stack osteotomes, make sure the troch osteotomy is complete anteriorly before you start lifting. Patience is virtue, as I said before. Cemented well-fixed stem. This is a patient that was operated in Africa and had a revision in India. Then he landed up in US with a dislocated hip, has been dislocated for months. He's an 82-year-old guy, quite functional, and he had extensive cementing, as you can see, and taking it out of the ETO or any other ways probably will destroy the proximal femur, require a PFR. We tried to salvage it and did a cement and cement, so it took the stem out and used a smaller stem in the same cement metal, which seemed to be well fixed, and it really worked well. And this is another technique you can use if you want to avoid ETO, particularly cemented stem that has a good mantle of cement and not infected, obviously. Uncemented cup. How to remove an uncemented cup. Many of you will be very familiar with the explant system from Zimmer. We use it almost every case. This has changed how you do revisions. Certainly a must-have tool for removal of uncemented cup. What you need, typically good exposure, circumferential exposure. Make sure you have the appropriate screwdriver. Many of them have screws, uncemented cup, obviously. If there are screws, make sure you have an appropriate screwdriver. This can be a pain otherwise. To remove it, if you strip the screw head, then it's really adds time to your surgery. If you do strip it somehow, then you can use a metal cutting burr to essentially burr out the head, and then obviously it'll be painful to use this explant, but it can be used around the screw, and ultimately it can still be done, although with more difficulty. Broken screw not on the way can be left alone. But again, obviously, if it's infected, you may have to take it out. But if it's not infected, it's okay to leave it. In old cups that are well fixed, is not infected, cementing a liner is an option. Use a metal cutting burr to carve out in the inner surface of the metal stem so that it fixes all the cement, and you can cement a liner into the cup again and not have to remove the cup. You can also use trial head balls fixed with bone wax. If you don't have an appropriate head ball, they can use the trial head balls to use this tool. So some of the tips and tricks to how to remove uncemented cup in this one. Acetabular bone glass, metal augments. So this is my typical way to go for a significant bone loss that requires some sort of reconstruction. It avoids the issues of the bulk allograft like aseptic loosening or graft resorption. It does come in different sizes and shapes, so certainly very modular. The downside is it does not help in restoring bone stock. So if it's a younger person, certainly something to think about carefully, that in another 15, 20 years, if you do go back for a revision, you really keep losing more bone. So maybe preferred in older people, and maybe bone grafting is preferable in younger folks. Some of the reports, porous metal augment with uncemented cup, as you can see, has a very good track record for aseptic loosening survival rate, so almost 100% or at over 90% at minimum on almost all the studies there. So certainly has good track record there. This is a patient of mine, had a significant osteolysis. I think it was done in 98 or 99, something like that. When my ex-partner revised this with a liner exchange, and something to be very careful when you have such significant bone loss, that it may not be very well supported. And as it happened, then it collapsed into the hole. So maybe the way to do for this is probably open the window on the bone laterally and pack bone graft. It's very difficult to graft this entire hole through the cup using that the holes in the cup. So if you want to accept this, then probably I would recommend bone grafting from a window supralaterally, or whichever way you can access it that address tabular area. Other option is to revise it and fill up with the augments. I put 2 augments here. There are 2 dome augments essentially to fill the cavity. This is about 2 years post-op. She's an engineer in NASA, did really well. She's 80 something, but really did well, afterwards. There are a couple of ways you can put augments. Augments are classified into what we call footing, which will be real medial. A dome augment, as it shows in here, a dome augment supports the dome area. And then a flying buttress, which goes on the side, as described in this picture, where it sticks to the side. In this one, I used, there was a dome augment already placed by outside surgeons. Cup was retroverted, and she was dislocating. So we had to change the cup, and then I had to do more augments to have a better supported cup in a better position. And then she did well afterwards without issues with this. For bone loss, you can use an augment combo. This is a patient of mine, had a couple of revisions, I think 7 revisions before he ended up with me for various reasons. As you can see, there is no discontinuity, but there is a significant intercolumn and medial bone loss. This is classified as Peprosky 3B without pelvic discontinuity. Now, there are several ways you can do it and fix this one. For me, this was infected, so I had to do it 2 stays. The stem was so well fixed, I had a tough time removing it. It did have a complication, as I described before, had a femoral staph fracture that initially we put a nail spacer, which healed nicely, and then went back and put a flying buttress on the lateral side and a bone graft medially. Again, he did well. He followed up for, I believe, 1.5 years or 2, and then has been following locally. Comes from a distant place, but he was doing really well until that point. As you can see, the cup is pretty big. It's a jumbo cup. I believe it's a 66 or a 68 cup, and then that give us a good column support, and then uncovered cup was supported with the flying buttress, and the medial side had bone grafted it, and it has nicely incorporated. This is another example of acetabular bone loss where 2 augments were used to reconstruct. This is a 2B defect. Even though it's a 2B and there's a fair amount of bone loss in this one, I accepted a slightly high hip center. As you can see, I used a dome augment and a flying buttress. And again, the patient did well, with a good follow-up. This is another patient that was referred to my partner, and I helped with the surgery in this one. I had a significant bone loss. The key part for this one, if you look at the CT scan, there is absolutely no bone to anchor. This is the most lateral and superior bone loss. You barely have a posterior superior iliac spine. This makes it very challenging. Even though the anterior column is intact, as you saw in the CT, there is absolutely no posterior column, no sciatic buttress. It's essentially we're riding on the sacroiliac joint. And this is very technically challenging. You cannot use a triflange even in this one. There's nothing to anchor. So we went innovative on this one. We use stacked augment concept. We stacked several augments. So I used augments and combined them with cement, and then use it first almost like a dome. We secured that to the almost SI joint, whatever left out ilium I had posteriorly to that one, and then build up with the 2 more augments, and then a pretty large cup. Even then we kind of barely restored the center is still about 1 centimeter up. But this is where the most of the bone is available for me to have some kind of support. She did actually quite well, but she had a 1.5-year follow-up. For mechanical regions, she did really well. As you can see, the augments did grow into the rest of the bone. The cup seems to be stable. Mechanically, she did really well. So stacking augments is an option in situation. This is actually published. This is another one. I showed this picture before. This is a patient of mine that you can see after explantation barely has a acetabulum. It's like a 20 or 30% of the acetabulum is left. This is the big hole that is almost to the, you can feel the sacroiliac joint almost there through that hole. So I use a trabecular metal cup for the socket, and then I use stacking augments. You can see 2 augments are stacked and held together with cement and secured to the side of the ilium, and then another 2 augments to build the rest up of the socket to have some kind of support, and a 5th augment on the side as a flying buttress. That's 5 augments together. Unfortunately, these are complicated situations, and a bulk allograft is certainly something you can consider in some situations. This is an old guy, needed to work right away. He actually did well until his death. He died of pancreatic cancer, but he was doing really well at his follow-up. He healed well. Overall, was quite happy. He hadn't walked in 2 or 3 years. His initial hip surgery was done in 1981. And you can see that's a follow-up X-ray. The ETO healed. Augments are holding, and the cup is held nicely and at a stable hip. As you can notice, he has an ankylosing spondylitis with a fused spine, but he did well. Now, this is published very recently from HSS group, where they describe the same technique as we have been doing from before, with some good medium-term results. I think the follow-up was like 18 months or 2 years for them. But again, this is a described technique and nothing new. Certainly very expensive technique with so many augments to put, but sometimes there's not much options in these situations. Bulk allograft, certainly cheaper. Type of graft and surgical technique will determine the success. Fresh, frozen, and irradiated graft do well, while freeze-dried have a very poor track record. Minor column graft, which means when you have less than 30% to be covered, have a better survival, obviously 67% survival at 15 years and a 61% at 20 years is not terrible. And it's obviously quite cheap compared to augments. This is something I use pretty routinely. You can use an allograft, or even in a primary hip situations with a lot of bone loss as autograft, revision situations, allograft. This is the technique. You can take the femoral head ball, you cut it on the side of a superolateral area like a 7. You usually keep the calcar area or the medial side because that's a stronger bone. And then this is attached to the side of the ilium or superolateral part of the acetabulum, where most of the bone loss is typically usually secured with 2 screws. And then you ream it like you ream the acetabulum, not eccentrically, but you come out as if you're going right straight and the centrically in the acetabulum. You start reaming, obviously that means you'll hit the head ball first. So you start reaming that way, and then you make it a socket like this one. This is an intraoperative example of one of my patients where I put a femoral head graft, what we call a 7 graft or a poor man's 7 graft, and then secured with 2 screws there. This is nicely healed. This is 2 years follow-up. You can see it's nicely incorporated. This is an example again on a pictorial description. This is the real intraoperative scenario, and this is a post-op case. And this might be quite helpful both in a complex primary situations or revision situations, and probably avoid an augment and the situations. Some of the outcomes of the bulk allograft, as you can see, it does well with the uncemented cup. There's a very high failure rate for component loosening when a cemented cup is used. It's almost 50% in many series, 45, 66, 32% component loosening. But although graft union rate is pretty high. So even though sometimes it might fail with the graft heals, you can certainly re-revise it. Not ideal, but certainly in some of the situations are already quite complicated, and you know, you might have to do whatever it needs to be done. This patient, actually one of my nurses' father-in-law had a femoral neck fracture and had a hemiarthroplasty and has a rapid erosion of the acetabulum. He was lengthened a little bit. I guess the pressure from the increase in length as well as previous soft acetabulum or arthritic acetabulum led to rapid erosion. He was in severe pain in a year and was completely wheelchair bound. We revised this as 85-year-old. We try to minimize stuff. It was a contained defect, so I used bone graft to pack it and put a large cup and fix some screws with that. This is a year post-op. He's actually almost 4 years now. He's doing really well. No issues. 89, still walks. Use of jumbo cups usually gives a larger surface area for ingrowth. It's a little simpler surgery, but again, you lose more bone, and it produces slightly high hip center. But it avoids all this grafting, augmenting, or various other reconstructive options. So certainly an easier technique when possible. As you can see in these pictures that was published, and as you start reaming, as you put bigger and bigger cup, you start to ream the walls out. You can see how the anterior posterior wall is almost gone. You get some mediolateral to hold it. So that is some downside to this, but upside is the simplicity. This is the example of a patient of mine that was referred to me for a 3B defect without pelvic discontinuity. Use I think 72 cup, and then multiple screws. I also bone grafted it. This guy didn't follow up for long. I don't have a long-term results, but until his last follow-up, he was doing really well, had no pain. Another example, a patient of mine, again, I didn't do the initial surgery. I was actually a fellow when this surgery was done back in 2008. I was part of this surgery. Unfortunately, patient had posterior joint infection about 8 to 10 years later at a MRSA. We had to do 2 stays, and then we tried to salvage it. I actually didn't use a constraint liner. This is a 78 cup and a bipolar head ball to make it a tripolar construct to make it more stable. It actually did really well. He's like 4 years out, and did well for the hip part. Again, these are options. You can use jumbo cup to get away with the bone loss and the revision situations without any augment sort of grafting. Another way to reconstruct bone loss with pelvic discontinuity will be a cup case construct. They used to do what we call before a case cup construct. So you used to do case first and then cement a liner to it. And that seemed to fail because case doesn't grow in. And then ultimately, if the pelvic discontinuity doesn't heal with chronic fatigue, that failed significantly. But since then, the technique has been changed by Proximal et al. And they put a cup first and they let the cup have some bony contact there. and then protect the cup with the case. This is called a cup case technique, where the cup is first and the case comes next. And then it allows the cup to heal because this case works like a hammock and protects it on the inside from any motion. And when the cup heals, it has a lot better chance of survival because now it's grown in, it's part of the socket. So then you cement the liner with good results at the medium term, like 88, 89% survival. Before this is almost 50% failure rate or even more than that. And so certainly a technique that can be used on this Paprosky 3 defects with pelvic discontinuity or any kind of pelvic discontinuity. This probably should be the advisable technique. This is a patient of one of my partner had a previous acetabular fracture and a total hip with a reconstruction. Unfortunately, over time it failed. As you can see, there is a posterior column defect. There's no intercolumnus, like a flimsy bone there. There's pretty much nothing there. This is one situation which I will say is a 3B with pelvic discontinuity. This will be an ideal situation for a cup case technique, which we did. So I use a DePuy case. This is a lot more stiffer. It does have normally a flange. I many times cut it out with a metal cutting burr, but keep a hole closer to the rim for me to have at least one screw. This avoids it's very difficult to position a case when you have the flange up and down, and it really adds a lot of time. So I would use this when I have some bone stock at the rim available. Then I would cut the case at the bottom and use a screw at the bottom. Obviously the top part is a little fiddly too, then you can, that's usually something you learn with experience. But anyway, we put a big cup, which is, I don't remember the cup size, it was jumbo cup, but then you use a cage to protect the cup, and then we cemented a liner. I do use a tripolar construct for stability. He's a bipolar head ball instead of a regular head ball. And then he's still doing well. He's at thing 3 years out. He's due for his follow-up, 2 years follow-up. He was doing really well. Had no issues with the cup. It's nice. You can see how the bone has grown in there. Pretty much the cup is grown in and it looks great. Another example is a patient of mine again. Again, he had multiple surgeries before on the left side. Ultimately, I explanted it, and I did put this one, actually, it has twisted around now. It's unfortunate. Had a bilateral pelvic discontinuity. This I revised it bilaterally, and the right side was challenging because, as you can see, there's pretty much no acetabulum there. It's like a flat bone. So what we did is we put an augment on the medial side, and then that put screws to hold it, put an augment on the lateral side and put screws to hold it. Then we distracted it using the acetabular distractors, we call Youngblood distractors. And then I put some cement on the augments and stick in a large acetabular cup between the augments. I didn't have any bone to hold on, but to basically rely on these two augments that are well fixed to the acetabulum on either side, and then essentially cemented the cup into the augment, and then put as many screws as I can through the cup, and then use a case to protect my construct, and then cemented a constrained liner. And obviously challenging. We did the same thing on the other side. I didn't have to use two augments on the other side to distract it. But I use a distractor to distract the chronic discontinuity, then apply a large cup and then protect it with the case. Like I did in the previous case, I cut the bottom end of the case and then I use a rim screw to hold as to the acetabulum. Again, mechanically, this did really well. She has no groin pain. And the last CT scan showed some healing of the discontinuity. Overall lesson learned: acute discontinuity needs fixing, chronic discontinuity needs distraction and bone grafting. In our experience, case with ischial screw works better. As you can see, this is another patient of mine. This was again done outside, has a case that has actually ingrown surface there from a company. and has a slot, has a flange that has a slot to go. But the problem with the slot is many times so crack the ischium, like in this case, to crack the pelvis, and essentially the whole thing migrated up now without any stability. You can see the case broke. And in this patient, a lot of complications done with this, as this was done outside, had a iliac vessel injury, had a sciatic nerve palsy, and had an infection, underwent a 2-stage surgery with me, with another cup case with the construct I use with the ischial screw. As I said, you can shorten the ischial flange using a metal cutting burr. Overall, higher failure rate as expected, this complicated surgeries, but a viable option in a type 3B laparoscopy defect with pelvic discontinuity. Now, another option of the reconstruction of the severe bone loss is a triflange cup. It's a defect bridging instead of a defect matching. Typically for 3A or 3B defects, obviously you don't want to do it on anything less than 3. It's a 3D CT scan based. Overall, the concern is cost. It's obviously expensive. Again, a feasibility of biologic ingrowth and long-term effect of a stiff metal and a harsh push bone, something to think about. Overall, good midterm success rate is almost 90% at 10 years from the DeBoer study. This example of a patient, actually done by my partner, came with a loose acetabular curve. This was done over 20 years ago. As you can see, there's a severe bone loss. There's nothing pretty much on the acetabulum. Initially, an attempt was made to salvage this with the dual augments there. Unfortunately, patient fell a couple of days post-op and broke the posterior column and pulled out the cup. So this was revised with the cup technique, another useful technique to consider on a significant bone loss as a salvage option. It looked good. It was stable intraoperatively, but unfortunately, it did dislocate. As you can see, post-op, he came back 5 weeks post-op and said he might have dislocated a week or two ago. At the time, he was taken back to the operating room, but there was concern for infection. So the implants were taken out and a spacer was placed instead. Cultures actually were negative afterwards. So, but at this time, the bone loss is severe. There's really not much to reconstruct here. Again, stacking augments was an option, but at this one, we decided to put a triflange. We had some good iliac bone to hold on to, as you can see in this one. If you compare with the previous case I presented, that was a tiny bit of bone left out on the top, but this is a lot more bone for us to anchor. So a triflange was done. This patient is doing well at 8 months at this time. Lessons learned: you can sterilize 3D model. You can put it intra-op. It's actually a very useful way, pretty much to navigate when you're operating. Do need a wide exposure for this one, but again, if you dissect it too much, it might lead to instability. Always try to shorten the iliac flange. That's always the pain otherwise. Fix the ischial screw first. Bone graft medially and do not lateralize is key, otherwise it'll fail. 20% revision rate, mostly due to instability or prosthetic joint infection. Constrained liner is preferred because of the, as you can see, the dislocation is probably the most common complication. Coming to femoral bone loss, this is a patient of mine, again, done outside, had a metal on metal hip replacement with a significant osteolysis, both on the acetabular, but more so on the femoral side. You can see in the CT extensive bone loss on both sides and the pseudotumor burden there. So we did an impaction grafting in this one using a striker mesh to hold it. And you can see at 2 years follow-up, it's nicely packed and regrown the trochanter, reconstructed the whole thing. Patient overall did well with that. Again, this is a patient done by me. It was done by my partner initially. It's 26-year-old, requiring a constrained liner after multiple revisions. Again, presented to me after dental work, didn't have dental prophylaxis, ended up with a strep viridans infection, had an ETO, and then a spacer put in. Unfortunately, she fell and broke the femur. And this makes it pretty challenging, but she was already 4 or 5 weeks out, had enough antibiotics. We decided to salvage this and not put a plate and put an allograft and held it together without putting any metal and screws. And then ultimately ended up with a fully coated stem. She's actually more than 6 years now. She's done in 2016. But you can see how nicely allograft incorporated in the proximal bone, reconstructing the entire bone. She's good range of motion. Unfortunately, she tends to bend over 180 degrees, hasn't dislocated. As you can see, it's nicely anteverted. That was our initial problem with recurrent dislocation. That's why we anteverted it enough, because she's obsessed to bending the hip this much, which I normally don't expect, but again, she's doing well with that. Another example of severe bone loss, it's a 3B bone loss. It's another 80-plus-year-old lady, had an outside surgery, had a fall, periprosthetic fracture, everything done outside, was referred to me with the infected hip joint with a severe bone loss. We initially took out all the hardware out, put a nail spacer, and then afterwards the option was either a modular fluted tapered stem or a proximal femoral replacement. Again, I don't think anybody would blame you for doing a PFR on this one. We decided to do a modular fluted tapered stem. Again, I use a flying buttress to reconstruct the acetabulum bone loss. On the femoral side, I use a modular fluted tapered stem. And I held well without any issues. Overall, she did well, and this construction worked. The advantage of the modular fluted tapered stem is it has the proximal body necessary for revisions. You can optimize length, version, and offset with the proximal body. If necessary, it's an easier revision compared to some other options available. Some of the tips and tricks of using a modular fluted tapered stem: I usually do a reamer by hand, first reamer for sure by hand, and get the best fit reamer. The reamer must scream. If you do reaming, you can hear the screeching of the reamer. Is necessary for that thing to happen in most situations, except on severe bone loss where there's not much bone available. Obviously, don't expect that. It's not uncommon to perforate it internally, especially in a short stature patient. The stems are typically around 140 centimeter length. So, 140 millimeter lengths or 14 centimeter lengths, and they typically bypass the isthmus and then the curve area, especially in a short stature, and it will come out on the front many times. So typically I would use fluoro, especially on a short people, and make sure that this is not coming out on the front. This is very, very common. Beware of the troch position, because many times the troch is malunited and can force you to go in a certain way. Pre-op templating, especially on the lateral view, is important. Understand your system. Reamer taper, it is of paramount importance that you know your reamer taper and what works. Subsidence is uncommon, but almost described in 11% cases in some series. It is not a sign of loosening on modular fluted tapered stem, and almost none of the ones that subsided have been considered loose. Even in my series, I have seen a couple of subsidence. I haven't had any revision on any of the subsided stem, and they have no issues with the stem. So another patient of mine referred to me for this periprosthetic fracture with a loose acetabulum and a loose femur. This is a lady who was really short. She's like a 4'6" or 7 inches. This was a tough situation. She had a loose implant for a while though, and she was aware of that. But then this fracture, we decided to salvage it. Her aspiration search cell count was over 30,000, so we suspected infection. So we did a 2 stays, even though our cultures were negative. We tried to put a nail and a construct like this to temporarily use it as a spacer. This actually worked really well. And then when we revised it, I did have a perforation in spite of all the watching and looking at it. I couldn't get a good fit, so did a perforation, I protected with a plate and a stem. Obviously, even though this is the shortest stem, it almost goes to the knee. Our cultures are always negative, intra-op cultures are negative, so we left the cement medially as it is, and then use a large cup with the screws medially laterally to hold it well. Again, she did really well. She has been now 5 years now. The last follow-up I had was 3 years ago. Coming back to proximal femoral replacement, higher failure rate, typically used for salvage, mostly older, less active patients. Again, dislocation rate is pretty high, it's about 19%. 73% survival at 5 years for Pervizi. Again, other cities, almost 64% with a 22% dislocation rate. Overall complication rates are higher, almost at 27% for many cities. This is a patient that was referred to me for revision, again, as a complicated situation. Patient had actually broken implant, outside surgeon tried to, I guess, didn't recognize broken intraoperatively, had a difficult time. And then the femur broke, and then the stem also perforated. They tried to salvage it with a plate, and unfortunately, there was not recognized that intraoperative perforation of the stem. But this patient has been walking on this for 2 years until she was seen by me. Again, we chose to do a PFR on her. I typically preserve the trochanter for abductor function and wire it if possible. Again, I try to figure out 8 wire there. It held well. She's still doing well. She's 2.5 or 3 years out, and she's pretty happy with her construct. Now, coming to total femur replacement, this is a salvage option for massive bone loss, only done when you have less than 12 centimeter femur available for the stem. I always do a CT of the contralateral femur for length. That is very important, because that's the key thing to get the length right in these ones. Ideally, lateral positioning, I've done both ways. I've done semi-lateral, almost close to supine, versus I've done full lateral, and they both seem to work without issues. High complication rate, mainly due to instability and infection. There's a patient that was referred to me. Patient had a previous DFR, then had a fractured neck of femur, and an attempt at a screw fixation that failed. I don't see there's any other option on this one other than a total femur replacement. So we did that. I used a constraint liner. Again, I preserved the trochanter with a figure-of-8 wire to hold the abductors, which has always worked for me. So did well. She had other issues, COPDs, obesity, other things. Her mobility is limited, but she has no pain, and she's doing well at a 1.5 year follow-up. This was another patient referred to me. He had a total femur done in Pennsylvania, and then he presented to us with a dislocated hip, also had infection. He was growing Corynebacterium jacium. It's a bad bug. So we explanted that. I use my customized spacer. There are many other options available. There are some company-made spacers available. I chose to use this. This was cheaper for me at this time. You could use the curb end on the top to keep this ball inside, but again, I don't expect this to be stable. So I wasn't worried about it. I wanted some length and some stability for the thigh until I can go back and replant it, which we did. A couple of months later, once they cleared the infection, I used a total femur and then use a cone and a stem concept. I had a TTO before. And he did really well. He's only 6 months out, and so far hasn't had any issues. That would be probably the most of the reconstructions options available in a short, concise lecture, as much as I can do. Hopefully this was helpful and useful to you guys. Thank you very much.
Thank you, Jib, for that brilliant talk and absolutely fantastic array of cases. And I'm very proud of the work that you're doing at VCO. Congratulations for that.
Thank you.
Jib, you can stop sharing, actually.
How do I stop sharing now?
You just need to stop, press the stop button.
To get my zoom up. Oh, I see that.
Bottom. Yeah, perfect.
Thank you.
Jib, a couple of questions from our side. Now, you mentioned about extended trochanteric osteotomy. Of course, it's a fantastic option. Now, when you extended, some cases you mentioned where the stem is fixed more distally than expected. and you would like to extend it more distally. And do you think, do you always put a prophylactic wire so that it does not give way, or in case it goes off, you can just wire it there?
Right, I usually put a wire distally because I have seen that split can really propagate distally quite a bit, and you can really put in a bigger mess than you're already in by trying to extend it. These are obviously salvage options, and you really don't want to do this if possible. Certainly has its own issues, but once you're stuck in there, like particularly I've seen this with the summit stems. So the one I used, that one, it was a 10 stem, and they're very long. They're 17, 18 centimeter long. And sometimes it's not that every time you will have a problem with the shoulder ETO. Most of the time you get away. You can always cut the stem. Summit stems are hard to cut, but you can cut it, and they're cylindrical distally, so you can use it Trifine. But I'm talking about where you don't have much options. Then it's easier to split that, and it is no repercussion to it unless you need to replant right away. If you have to put a stem right away, then you really don't want to do that, because then you don't have a stability, right? So that will be a difficult choice to do that. You're in a difficult situation. You really have to bypass it all the way down to the knee, which is even more complicated than that. So yes, certainly you can split it as necessary. I've done that a couple of times.
Thank you, Jib, for that. And Jib, you mentioned about managing acetabular bone loss, a fantastic collection of cases. Now, before we used to talk about the impaction bone grafting, right? The slough technique, and how popular is it? And what are the combinations available? For example, when you talked about a cup cage construct, you said, okay, you can put a cup first and then cage, and even you can cement it in between. So when you use bone graft, cement, and then augment in the acetabular, what are the combinations possible, and what is the best way?
So for impaction grafting, typically I do not do in a cup case. Typically it's not necessary. You have enough bone stock attachment there, and if a protection with the cage, they tend to heal well. I mean, you need only 40% bony contact for a cup to heal. You need only 20% of growth into the cup for the cup to be well fixed. So you really, like I showed in one of the examples, you only saw like a 30–40% acetabulum left, and that guy really healed well, having a nice trabecular metal cup. I use impaction grafting mostly for contained defects. I do not use the old technique like I used on the femoral side on one of the cases where I use a striker mesh. You can do that as an option. You have to protect the weight bearing for those cases, especially the big bone loss that do have a higher failure rate overall. So technically, while it is a cheaper option in certain times, you can use it. You have to keep them non-weight bearing, for this bone graft is not going to hold you, especially if it is in an uncontained situation. So for me, in US at the time, the only time I would do impaction grafting would be in a contained acetabular defect where I can contain the graft. Or on a femoral side, I do use impaction grafting a little bit more often because it's not kind of a weight bearing area. So I can still let them weight bear with a bypassing stem or something. So I would use on a femoral side and a proximal bone defect. I would use sometimes impaction grafting on the femoral side inside the femur for the intramedullary grafting for some of the bone loss in a non-infected cases. But that would be the most indication for me for impaction grafting, but not the ones where I feel like it will affect their weight bearing or a failure rate being higher with that, because I have more options available here.
Thank you, Jim. And when you use a cup cage construct, like you mentioned, sometimes you said you use cement in between, right? So is it between the cup and the cage? Is it the location?
No, the cup goes first as a press fit. The cage goes next as a standard, like a hammock, and then you cement a liner into the cage. So basically, the cup, the liner, and the cage are supporting the inside the initial metal construct you put in. So they become unitized to that cup when you cement it. And so basically, but the inside is almost like a cementing a liner to the cup. Instead of cementing a liner to the cup, you're cementing a liner to the cage. And the cage instead is buttressing the cup inside. So that's kind of how it works. So the cup, then the cage, and then the liner. Liner is the only one that is cemented.
Thank you, Jim, for that. And these are really complex cases where, of course, there are issues with muscle and late instability. Of course, you have mentioned about the issues of instability and infection are the biggest complications. And do you think a combination of a dual mobility in such a situation is going to work?
Yeah, so like in some of the cases you saw that I put a tripolar construct, which is a very similar to a dual mobility, but a cheaper construct. Dual mobility is definitely an option on stuff that you feel like instability would be an issue. I don't see dual mobility do anything different if it is impinging or if it is abductor deficiency or significant soft tissue defect. It doesn't seem to help a whole lot. It certainly makes it more stable for something that is borderline stable, right? But if it is unstable, then dual mobility is not going to do much. So all I do when I'm not against dual mobility, is very helpful. You can't rely on it on its own if it is unstable. You must make a room for that. If you think that it is unstable, you might want to use a constraint liner or something to hold it. But don't rely on dual mobility helping you on an unstable situation. It will make it a little bit more stable, but not enough to bypass the other options. So the tripolar constructs I have used, the hip was already stable to some extent. I would have probably been okay just with the normal thing, but it adds to the stability significantly when I use a dual mobility construct on my situation. So that would be a warning thing. I have seen dual mobility dislocating when people relying only on dual mobility as, okay, let's put a dual mobility, it'll work. I don't see that working that way. You must address your primary problem. The cup is retroverted, you fix it. The stem is retroverted, you correct it. If there is impingement, you remove the impingement. If there is abductor deficiency, you probably should constrain and not rely entirely on dual mobility.
Thank you, Jim. Just one last question before we wind up the session. Now, some of these revision cases, we think that there's a lot of osteoporosis, like some paper-like femur. Some people call it like just a thin piece of paper. So do you think there's a role for a prophylactic teriparatide before you really go in for the surgery?
I certainly think so. It's just something there is not much studies or publications to support that. I would certainly think a patient can wait some time. It is absolutely, I would consider that every time. It is just hard in US to get these things done with insurance and everything else available, and patients are mostly, they don't want to wait another 8 months, 9 months, 10 months. It is definitely an option though. I would consider in every possible case where there is a known osteoporosis to treat them prior to revision if it's possible.
Thank you, Jim. I think that's all the questions that we have for this session. Thank you for yet another fantastic talk, and I'm sure this is going to benefit a lot of people all over the world. Thank you so much, Jiban.
Awesome, Hitesh.